Marwan asked me to talk about this topic, designing the ideal contemporary shock trial, and I'll start out by saying I am not a shock person. I am a heart failure person, so I'm going to be looking at this from a heart failure trialist perspective. And I guess my other main claim to fame here is I run the program that trained Marwan and sent him to you. So we're very, that seemed to have worked out pretty well, so we're very proud of him. So I have one little disclosure there. There are many challenges. I've learned so much here in the last day or two of challenges for shock trials. One is that, as you've heard over and over again, there's various variable etiologies. These are some data from one of our fellows presented at TCT a few months ago from a shock registry, almost 1,000 patients. And the thing to focus on here are the etiologies. And you all know this. People come at shock from many different diseases and syndromes. That's one problem. The hemodynamics are very variable. Again, from this registry, this was about 500 out of the 1,000 patients that had SWAN data. And remember our discussion yesterday about, everyone should have a SWAN. Here, only 50% of people in the registry. And you can see that the hemodynamics, right atrial pressure on the x-axis, wedge on the y-axis, were really all over the place. You could have patients with just an RV profile, biventricular failure. So the hemodynamics are very variable. The pathophysiology is variable. There are people with high lactate, high creatinine, low creatinine, all of whom have different categories of survival and outcomes, as shown here by Bill O'Neill, who categorized people by their lactate level and their cardiac power output and had different survival characteristics. So all of this, and then prognostic modifiers. Do they have RV failure? Did they have a cardiac arrest or not? As David talked about yesterday in the classification, do they have SIRS or not? So, and they present at varying stages, and here are the different stages from the preliminary classification that David talked about yesterday. So how in the world do you ever gather this together and do clinical trials? Oh, and by the way, they present to your academic medical center, or they might present to one of the spokes out there and are sent to you, and those people are probably going to do differently. Oh, and by the way, you have a lot of different ways to treat these people. A lot of different devices for the LV, a lot of different devices for the RV. So again, how in the world can you possibly design trials to account for all of these variables? So, when a heart failure person hears, gee, we're still fighting about the nomenclature, and oh, there's variable etiologies and pathophysiologies in multiple neutral trials. When a heart failure person hears this, you think, oh, that's just like HFpEF, by the way. So we've been doing this for the last 15 years, and I can't say there's been a lot of progress. We've been fighting about nomenclature for 15 or 20 years. Back in the early 2000s, this was called diastolic heart failure, and we thought everybody had LVH, and the whole thing was a diastolic pressure volume problem. That doesn't seem to be the case at all. And now we think of HFpEF as a clinical syndrome with lots of different inputs. You can have, yes, abnormal diastolic function, relaxation and compliance, hypertensive heart disease, vascular and ventricular stiffness. You can just have obesity and the metabolic syndrome, and an inflammatory milieu seems to be able to cause HFpEF. You can have chronotropic incompetence all by itself and cause HFpEF, et cetera, et cetera, et cetera. Some people, of course, have amyloid. Others have hypertrophic cardiomyopathy. And all of these people have different natural history projections. So this is not actually unlike what we've been talking about here in the last couple of days. And of course, in HFpEF, there's been thousands of patients studied in many, many neutral trials. We really haven't made that much impact. I hope you do better in the shock world. There has been some progress, I think, though. This is a really interesting paper that was published a few years ago in Circulation by Sanjeev Shah from Northwestern, and he had about 400 patients seen at Northwestern that he characterized with really highly annotated clinical data. Now, this is not a genomap. This is what he called a phenomap, where along the right side y-axis there are about 60 different clinical characteristics, demographics, echo characteristics, et cetera, and this is about all 400 patients here. And the clusters, he used statistical techniques to look at clusters that travel together. For instance, this little red area here that I highlighted is right ventricular abnormalities on echo. And using these techniques created or or found within this data set what he called different phenogroups that had different prognostic trajectories. So maybe you can take these same concepts, and we're thinking about this in the HFpEF world of trying to pick out these types of patients. Forget about the etiology for a second, just the types of patients and how they present, and maybe use this as a basis for entering randomized trials. It hasn't been done yet, but we're thinking about it. So what are the possibilities for the paths forward? So last year, as you may know, there was a think tank about this put on by the folks from DCRI, and there were some pretty good ideas there. Number one, expand the registries, gather these highly annotated data to phenomap, similar to what Sanjeev did for HFpEF patients, to theoretically inform patient selection for trials and interventions, and take these same groups that you put together for registries and then adapt them for trials, just like the NHLBI Heart Failure Network. And then, this is really important, I think, use contemporary adaptive designs and machine learning to continually leverage growing information. In the heart failure world, with trials now, almost all trials we're developing are using what's called adaptive designs. And you can read all about this. It's complicated. I don't really understand it, but I'll tell you what I do understand. This is an example of a paper that was published in the New England Journal last year. It was a trial called the DAWN trial, and it was about thrombectomy in patients who were presenting with a stroke syndrome who had a deficit between the clinical syndrome that they had and the amount of infarct on the MRI or CT, I think. And in essence, then they randomized people to thrombectomy or not. But the interesting part was the adaptive design that was built in. So in other words, the traditional way of doing this is you say, we assume the control group will have this % outcome, the intervention group will have this, we create a sample size, and then at the end, we hope we were right. Here, you adapt. You learn as you go using Bayesian probabilities, and you can adapt the sample size along the way. And here you see the sample size, go back one, could range from 150 up to 500 patients. They ended up stopping it at about 250 patients because they had enough information to go ahead. So it's a very economical way in these difficult clinical syndromes. Here's another example called a randomized embedded multifactorial adaptive platform. And this I found in preparing this talk. This is actually an infectious disease trial, and I don't know anything about infectious disease, but it's community-acquired pneumonia treated in ICUs. And there's a mechanism where the patients receive many different treatments. You allow the information already in the study to help new patients joining the study. You test several treatments at a time, just like all the devices in shock. And look at the results in an ongoing way, and let the results inform you about how to continue the trial. Drop treatments if they're not effective. You could do this with devices in shock trials, and add new treatments to those that have undergone testing to complete the evaluation. So you can use these techniques in these very challenging clinical syndromes to just study patients and interventions in the most efficient way possible. It's an incredible challenge. We're dealing with it in the heart failure world, and I think there are a lot of lessons in the heart failure world to adapt to the shock trial world. Endpoints, 30-day mortality is probably pretty good because it's high, and maybe just do a comparative trial to an objective performance criteria like we do with devices, and don't necessarily have a control group. Randomization within registries. So there's a lot of things you can do in these very challenging clinical syndromes to move the field forward and really help the patients with this really terrible syndrome. And aligning reimbursement incentive to drive the registry data. If there's new devices, figure out a way for them to get funded only if people enter into a registry. We're used to doing that, with valve procedures. We should be doing it in shock as well. Thank you very much.
So, Jim, I love the idea of event-mediated trials, but one of the words that that you could use as an adjective or a synonym for adaptive is intermediate analysis, which used to be a bad thing, and certainly was thought to confound some degree of bias. And my other question to you that I wanted you to see if you could propose an answer to is that I can't see a lot of sponsoring agents, whether it's the NHLBI or industry, saying, because everybody wants to know the budget, so saying it's going to be between 150 and 500 patients, you're saying it's only going to be between 10 million and 75 million dollars.
Yeah. No, it's a real challenge. Well, let me give you an example. So, we're doing a device trial in heart failure reduced EF, an autonomic regulation device, and it's not an NHLBI. It's a commercial sponsor, and we might get the answer for the outcome. This is a pivotal phase 3 trial, to present to the FDA, with as few as 500 patients or as many as 1,100 patients. And we don't know. And, for a sponsor, they have to be ready to go up to the 1,100, but they will be quite thrilled if it's only 500. And, I'm not sure, now, I think the Dawn trial might have been NIH sponsored, but I don't really know that. So it's part of the presentation that, here's the maximum, but it might be less. I think you have to think of it that way.
Cluster randomization trials in this area is something that would be a path to try?
Yeah, no, so randomizing either one center to do this and another center to do that, there are many ways to do that. That could certainly work as well. Is that what you mean? Just different centers to do different strategies?
Exactly. Sometimes that is more edible for some centers because they don't have to change their practice, or they can continue doing what. Of course, we have a lot of selection bias and differences, but if you do that on a broader scale with large consortia, then it might be something that would be feasible.
And if you build in a capture of sufficient data in order to adjust things at the end, you're right. There's always going to be some limitation to that. But if that gets you close to an answer, whereas we don't have anything now, then that's the way to go.
I think one of the big challenges is, with a complex disease is baseline treatments may differ and may in fact influence the response to your therapeutic intervention. So you wonder, would you need to define a standard treatment protocol and then add your intervention on top of that? Or in fact, would a standard treatment protocol itself be a therapeutic intervention to study, in your opinion?
Well, I think that's the lesson from that quick example I showed of the infectious disease community-acquired pneumonia study, because the whole idea was everyone coming in is going to be treated differently somehow. And again, I just found that, and I haven't studied it. But I think you're absolutely right. I mean, if you say we're going to study this one device, we're going to study the Impella, let's say, and everyone coming in, because we want to, like the typical randomized trial, we want to say the cause and effect is this Impella. Everyone has to be treated the same. It's just not going to happen, with this. And so you have to have more sophisticated methods to deal with that. And, you're absolutely right.
Any other questions?
Well, the adaptive design is working much better for drugs than really for devices, because indeed, as you mentioned, the REMAP trial is indeed looking at different ways of giving antibiotics, giving clarithromycin or not for pneumonia and so on. So they also look at other factors, but it's mostly several drugs. And so indeed, the idea behind it is that if one of the drugs seems not to be very effective, to switch this aspect and to continue just for the other main arms and to randomize more patients there. It's easy, I think, to do with multiple interventions, including drugs, but I guess that it will be much more complicated if we do this kind of things with a balloon on one hand, Impella on the other hand, ECMO on the third hand. I mean, it will be much more complicated to have really these kind of things. And then again, I mean, we probably need to have the experience of the centers and go to cluster randomization and stuff like this, which will complicate this kind of aspect of the trial.
Well, I think the word adaptive design means many different things, and in fact, in the regular heart failure world, it's the device group at FDA that is driving this forward much faster than the drug group, and there's several that are in front of them now, or that will be in front of them for pivotal trials that are using this kind of not what you were talking about multiple treatments dropping this group and that, but adapting the sample size using Bayesian probability. So that's where that's coming in for device trials. I agree with you. The concept is there, however. And, you know, in this syndrome, you have multiple different devices, and perhaps you have 30 expert centers, and 5 of them use this device, 5 use that device, 5 use another, and as you go along, maybe you drop one.
But one of the things which is not taken into account is usually the expected mortality. And if we go for the recent ANACOM trial on ECMO, VV ECMO in respiratory failure, it's, in my mind, a good way to show the failure of the trial. I mean, when you look at the difference in mortality, which is clinically significant but not statistically significant, you end up with a real dilemma there, because indeed it was a kind of adaptive design, because indeed the sample size was continuously looked by a statistician, but because the predefined mortality was not reached, well, it was stopped, even though it was very close to be significant for the numbers I have. So if they redesign the sample size based on the actual mortality, and they would have continued the trial and probably reached some significant.
Well, the one I'm most familiar with from these device trials is doing just as you said at the end, and Scott Berry, who has written about this, has called it the Goldilocks design. In other words, it's not too big, it's not too small, it's just right, the sample size, because it's informed as you go on by the actual event rate. So what you just described for that trial really shouldn't happen. It's either, if you either get an answer, you don't get an inconclusive answer, you get it's yes or it's no. Eddie, do you have something?
I was just going to say, Jim, first of all, that was great. And I like the summary with respect to the lessons learned. When you were talking about the lessons learned from another experience, I thought you were going to have acute heart failure trials. And I mean, HFpEF is interesting, but one question I have is, what do you think we've learned from the acute heart failure trials that spills over? And the second question I have has more to do with just a shot at taking a trial design, because we were just at UCARS about a month ago, and we had this session that was excellent on designing a clinical trial in shock. Stavros and Joseph and those guys had a session, and the one thing I took away from it is this symposium touched on timing. So instead of focusing on device itself, I'm sure the companies want to hear about their device, but strategy. So what if you design a trial of timing once we sort out as a community what is the staging of shock? Timing for a specific stage of shock. And of course, it can't be in a patient in extreme. If you're going to put that patient in ECMO, that's unethical. Can you have a timing trial? Because when we did Revive It, I want you to know, Revive It was a timing trial that was ultimately believed to be, it was going to be positive because of the crossover rate. We all thought that's how we would, Keith Aronson and the team, we all thought that's how we would get our positive trial. But then the equipoise just completely fell apart because the pumps weren't there. But
so I'll start with your first comment. The difference between acute heart failure and cardiogenic shock is that almost everyone with acute heart failure gets better, right? That's a big difference, right? I mean, so any trial, you're trying to make people better faster, and we've never really been able to do that. And no matter how, and then now your timing question, whether it's in like true HF where everyone was within whatever it was, 16 hours, or Everest within 72 hours, or others of 48. We've tried all of that, and none of it had worked. None of it worked, but because you're sort of chasing your tail. I mean, the patients are being treated actively, they're getting better, and therapies don't work to make things better a little bit faster. And the big, the opportunity is the aftermath, right? And post-discharge, that's the high-risk period, and not too much has worked there either, I guess. So, that I thought HFpEF was somewhat of a better, more apt thing to compare. And then when you say timing, do you mean in sort of the different stages that David was presenting?
Got a staging system for shock.
Yeah.
Got a staging system for shock. I think the shock teams are trying to come up with a, what does Naveen call it? Door to unload. Well, it's the other D, diagnosis to unload. Because you may have a patient in shock, the best hospitals, trust me, in the world have this, who's unrecognized for a day, 2 days, 5 days. And, I do believe that is, so is it diagnosis to unload? I would say that strategy may obtain something from the ER to the CCU, something like that.
Or using the staging system that David talked about. I'll let you comment, and why don't you go ahead, comment.
Well, so I think the problem is whether or not it's our system we proposed or yet another one. As cardiologists and as physicians, it's very hard for us to sit on our hands. So imagine even if you chose a stage of shock that you said, okay, everybody could agree, which is going to be a miracle. But if everybody actually agrees, look at like Naveen's work, which is very interesting. You have a patient, you see they're having an MI, they have ST elevation. Imagine you're going to put that impel in and sit and do nothing for a period of time. It's very, very hard. I've talked to people, been involved to actually do nothing. So imagine as a patient, you decide they're in shock. You know the mortality of the shock is very high, but they're not an extremis. They're in whatever group you agree on. It's going to be very hard to get people to actually just sit and do nothing. Usually they already feel bad because they've ignored it for 5 days and the patient comes at 3 in the morning. So the practicality of doing nothing in shock, even if it's randomized, the quick or the slow response, it's hard. I actually was a fellow when Judy Hockman's shock trial was going on. I was one of the fellows, and it was amazing. We were all thinking we knew the right answer to revascularize, and that just watching them was a mistake, but it was the way the trial was done. I find it hard to imagine that we could actually tell people to do nothing after they've recognized shock, but see what
Now,
happens.
were you talking about using the different stages to create buckets for trials?
Yes,
Yeah.
so the stages would be used to really find the population where there is equipoise. And I mean, just to answer, Dave, I agree with you. I mean, my heart would sink if I had a patient, but the equipoise would be there if it was a patient who basically had responded to 2.5 or 5 of the butamine. Now, a lot of people say that's not shock here, but that's still a high mortality patient. You see, I mean, it's still a 15, 20% mortality in-house, maybe 6-month mortality, 25. And the question is, randomizing a patient with whatever you want to call it, mild, moderate shock, to an early unloading strategy, because if we look at all the trial data and all the data in the field, it's 50% survival no matter what. You're not going to move the needle forward till you try strategies that you believe. Now, if mechanical strategies don't work, then okay, now we know. Now we got to do something else.
No, I'll give you an anecdote. When we were doing the 510K approval of the tandem heart, it was based on one of the testimony from a trial lawyer, by the way, whose father was dying, and I had to go and tell him, well, your father's dying on the therapy. He was on a balloon pump after a massive MI. In cardiogenic shock, we'll continue to do what we are doing. We have clear signs it's failing. Or I will put you in another device, which may or may not save you. We have no data to protect. Which one would you do? So then he says, isn't that an unethical response? I say, I have clinical equipoise because I don't know tandem heart works or does not work. He said, but you're telling me he's dying. So would I try something that I think I tried everything for my father, or just let him die because you want to put him on a trial? So it's a trifecta where ethics, a disease process with high mortality and high cost converges. You don't have an answer. Because you never want to be in a situation where you want to decide, okay, this therapy is good for my mother, but not good for my mother-in-law. So it's a double conflict. So that is the problem in this field. And so far, all this designing talks that we've been having so far with FDA amongst ourselves, that's where we get bogged down to what is the price tag of a human life? What is the quality-adjusted life here for an LVAD? Or what is the cost of the readmissions after you've saved a guy with already spent $1 million? Should be a lifetime maximum like Medicare does. You have lifetime maximum of 60 days. If you go beyond 60 days, you're on your own. Whether you die, live, anything, they're not going to pay for it. If we start busting the bank the way we are doing, that's what's going to happen to each one of us. We'll get a price tag. Now that price tag may be different for different people in the society, but there'll be a price tag, and you exceed that, good luck. What's going to happen? And that's where the difficulty we are facing as doctors. We have primary responsibility towards our patient who's right in front of us because we treat one patient at a time. But when you start putting this in a population and countries with different resources, then the equation is completely different. And that's the difficulty in this field.
All right, so we'll let our course director will have that last word. And David and I would like to thank moderators and thank all of you for your questions, and we'll send this session to a close.